Hello there, and a warm welcome to this EMIC Fireside Chat. My name is Gregor Henderson, and it's my pleasure to be your host for today's webinar. I'm a board member of EMIC, and I take a great interest in digital mental health. Today, we'll be talking about an extremely important topic, virtual reality-based therapy. Can it transform interventions for severe mental disorders in a cost-effective manner? Acknowledging the increased rates of mental health disorders, it is imperative to find new, effective treatments that can be scaled for clinical implementation. Virtual reality, or VR, is a promising technologically advanced mental health tool with high ecological validity. VR has traditionally been employed in treating anxiety disorders, but recent years have witnessed an interest in exploring the potential of VR for treating severe mental illnesses such as psychosis. While the evidence base is increasing, the preliminary findings indicate short-term VR-based interventions to be effective in alleviating psychotic symptoms in a potentially cost-effective manner. Our panelists today from Denmark have some promising research to share about the effectiveness of virtual reality for people with severe mental illness. And today, we will have a first-hand account from someone with lived experience who has personally benefited from the transformative power of VR. You'll hear from each of them soon, but first, I have a few quick points to mention about the webinar. Feel free to share your current location or area of interest. To do so, you can click on the three dots next to your name tag, choose Edit, and add your country or area. This allows you to connect with others who share similar interests. If you have any questions for the panelists during the webinar, please feel free to post them in the chat box during the Q&A session. I will do my best to include as many of them as possible in our discussions. Lastly, today's webinar is being recorded, and the EMIC team will soon share the recording in the EMIC Knowledge Bank. Now, it gives me great pleasure to introduce our first three speakers of the day. They'll be speaking one after the other, but they'll join in the webinar room in just a moment. Our first speaker is Louise Glentoy, who's the Associate Professor and Head of the VIRTU Research Group. Louise has a master's degree in psychology from the University of Copenhagen Institute of Psychology and a PhD and DMSc degree from the Department of Clinical Medicine in Copenhagen. She has a clinical specialization in adult psychiatry and psychotherapy and has been working as a clinical psychologist in and outpatient facilities in Denmark. Our second speaker will be Lisa Smith, a PhD student from the VIRTU Research Group. Lisa received her master's degree in psychology from the University of Copenhagen in 2011. She went on to work as a clinical psychologist at a mental health center in the Copenhagen area, specializing in both psychiatry and psychotherapy. Our third speaker is Lisa Mariagard, a clinical psychologist with the VIRTU Research Group. Lisa has a master's degree in psychology. In 2017, she finished her specialization in adult clinical psychology and psychotherapy, and she's worked for 9 years at in and outpatient clinics at Mental Health Center Copenhagen and 8 years at the Copenhagen Research Center for Mental Health. It's my great pleasure to introduce our three speakers. If you can come and join me in the webinar now, that would be great. Thank you.
Thank you, Gregor, for this kind introduction. So I will start by briefly outlining the rationale for using virtual reality in psychiatry and why we find it to be a highly promising mental health research tool. And first of all, we capitalize on the notion of virtual reality being real but not real. So this means that we can simulate reality to an extent that elicits the thoughts, emotions, and behavior that people experience in real life distressing situations. And then we can conduct a gradual, controlled, and repeated exposure to distressing situations or symptoms to help the individual overcome these symptoms. And we can see that in this way, we can achieve a highly personalized treatment approach. And at the same time, our participants know that this isn't reality, so they're more inclined to be exposed when we do it in virtual reality compared to real life or in vivo exposure. Then it's also what we can call a somewhat gamified therapy. So this means that it is very engaging and meaningful for our participants. And this is also reflected in the high levels of motivation and great retention rates we have in our ongoing studies. And finally, it may also be cost effective, so there may be a kind of economic advantage or an economic incentive to implement this treatment in real life clinical practice. And we have several ongoing virtual reality-based intervention projects targeting different psychiatric disorders comprising anxiety, autism, eating disorders, and more general use in psychiatric inpatient facilities. But for this specific webinar, we will be focusing on psychosis and presenting an ongoing study called the Challenge Trial.
Yes, thank you, Louise. I will briefly introduce the Challenge Trial, in which we are testing a new type of virtual reality-assisted psychotherapy for auditory hallucinations. Auditory hallucinations are often referred to as hearing voices, since our patients in a psychiatric setting tend to hear these malign, abusive voices coming up with very critical comments, which is causing a lot of suffering in our patients. In this type of virtual reality therapy, the patient creates an avatar to represent their most dominant voice. So here you see an avatar from our trial created by one of our participants, representing her malign voice. Then also she creates the sound of the voice, so that the sound, when she's talking to this avatar immersed in virtual reality, will sound like the voice that she is hearing. And this voice transformation is conducted in real time, with the therapist being role-playing with the patients, meaning that the therapist, as you see on the photo here, through a microphone talks back as the avatar to the patient, and her voice can then be transformed, sounding like the male voice that the patient created. This is short-time psychotherapy, only 7 sessions within the first 12 weeks after being included in the study. And then there is an additional 2 sessions later on to boost the impact of the therapy. The dialogues last only around 5 to 10 minutes, even shorter in the beginning, because it can be very anxiety-provoking for our patients to go into these dialogues. And that leaves time for the dialogues to be prepared in advance together with the patient, and also to have time to discuss these dialogues afterwards. There are different phases of therapy. Therapy starts off with what we call a confronting dialogue, in which the therapist, speaking as the avatar, will come up with typical abusive remarks that the patient is used to hearing from his or her voice. Then gradually, the therapist will make sure that the avatar becomes less evil and more compassionate. And then later on, there is a focus on increasing self-esteem in the patient, and also a focus on the future and recovery. So I will finish my part of the presentation with a flowchart, so that you can see how Patients are referred to our trial by mental health centers in Denmark, and all of our participants suffer from schizophrenia spectrum disorders, hearing voices that have not been ameliorated by antipsychotic medication. We included 270 patients. Here it says 266. We added 4 more and ended inclusion in June. And then half of our patients were randomly assigned to supportive counseling, and the other half was randomly assigned to VR therapy. Then in the spring, we will have the results and start to look into the differences statistically between the 2 groups. As you see, our primary outcome is the severity of auditory hallucinations. We have a lot of exploratory outcomes that I have not included in this presentation, but I can mention that our secondary outcomes are related to how patients perceive their voice and also the social functioning. So far, we've had a dropout rate around 16%, which is similar to other types of psychotherapy. And considering how severely ill our patients are, it's quite good. And most patients drop out around the first session, where anxiety is at its highest. Thank you very much. Now I'll introduce Lise Marie Gordon.
Hello. So I'd like to share with you the therapist perspective to give you some insights to how it's been to use this therapy with the VR as a psychologist. So first we had as psychologists to learn how to use the technical equipment, the hardware, the software, the VR headset, all that, the sound everything had to work. And all this was new to us. So, and psychologists are really, at least in Denmark, maybe not so used to using like technical equipment, and maybe they don't have that great an interest either. So this was a challenge in the beginning, and we did have some therapists that didn't progress with this. But once we had learned how to use it, we learned that we could actually create the patient's voice experience in VR. So that was quite amazing. And so we had this immersion, which gives the possibility for therapeutic change in the voice relationship, because the patient believes that he's very much in there with his voice or her voice. As a therapist, we had to be kind of an actor. So that was also something very, very new to us. We're not usually actors. So we had to play the voice in there. So that meant that we had to say nasty things because voices are usually not very nice, and they're saying not nice things. And we had to imitate that and say things like that to have that exposure and confrontation, like Lisa was explaining. So that was something that we had to overcome. And I think my experience was that you had to make sense of it yourself as a therapist to actually feel okay by doing this. So another thing that we had to do was to control the anxiety level. So VR really, at least for our patients in this trial, created a great anxiety level. So we didn't want to have the anxiety too high up so that people would have like a panic attack. So we need to control that. So we think that VR is a tool for therapy. We think it gives new opportunities but we also think that it's quite a lot as a therapist to actually handle all of that with the technical equipment also. So just dipping into one aspect of the therapeutic alliance. So we think that in all therapies, the therapeutic alliance is very important for the outcome of therapy. So how does VR play into that, and how does it affect it? And so as a therapist, we think that getting into the dialogue with voices, like in this trial, we can actually understand voices better and the voice experience better. And I think with that, we can also become actually more empathic. So that's a good thing. Another thing I think is that going into VR and going out again and discussing how was that exposure experience, I think gives a very intense shared experience with the patient. And we found that that was strengthening the therapeutic alliance. So another aspect that wasn't as good was about the facial cues. So we want to look at the facial cues to kind of know what the patient is feeling. And that was harder because the glasses were almost covering the whole face. So to see the eyes and things with the around the eyes was more difficult. And then I just put this picture there, the technical difficulties, because handling all that technical equipment was a challenge. And you have to imagine that a patient days before this exposure is very nervous, and you get there and you turn on the VR, and then if it doesn't work, that's very stressful. Then as a therapist, you have to manage, you have to take care of your patient, but also you have to get the equipment to work. And that is putting a lot of stress on therapists, I have to say. And so and if it ends up not working at all on that specific session, that is something I think can go into therapeutic alliance and also affect outcome of therapy. So thank you very much.
And now on to our last speaker, Vibeke, sharing her story on receiving this intervention for auditory hallucination.
Great, thank you. Thank you very much, Louise, Lisa, and Lisa. It gives me great pleasure to introduce Vibeke Andersen. Vibeke has lived experience of psychosis and has been in treatment in the Danish psychiatric system for 31 years. Vibeke has been hearing voices for 27 years. However, after being enrolled in the research project on treating auditory hallucinations, hearing voices, utilizing virtual reality-based treatment in 2020, she has experienced a complete remission of her voices. Subsequently, her schizophrenia diagnosis has been changed to schizophrenia in full remission. She has experienced the life-changing effect of VR-based treatment and is a strong voice in disseminating the effect of VR interventions in Denmark. Vibeke has participated in several public appearances on TV, in newspaper articles, telling her story with the aim of giving hope for the future recovery for other service users struggling with distressing symptoms such as voice hearing. Vibeke, great pleasure in introducing you to this seminar today.
Thank you very much. My name is Vibeke and I'm from Denmark. I'm 51 years old. I have been in mental health since I was 20 years old in 1992. I was diagnosed with paranoid schizophrenia in 1994. I heard voices in my head which told me to commit suicide. I heard voices 24/7. When I woke up at night, they were there. When I was brushing my teeth, they were there. They also told me that nobody liked me. I was not wanted in my family. That's how I felt at that time. I was worthless as a human being. I had severe psychosis and got a lot of medication for my schizophrenia. I put on a lot of weight because I could eat a lot all the time. It was a side effect of the medication. For 20 years, I went to hospital from 1992 to 2012. My life had no purpose. I was mentally ill and a burden for my family. That's how I felt at that time. I had absolutely no hope at all for recovering. I thought I should hear voices for the rest of my life. I had no trust in the caretakers in mental health. They didn't help me. I just got medications all the time. And when I told them that I heard voices, they just gave me a pill and told me to go to rest. In mental health, nobody told me about hope and recovery until I read a book in 2004 about recovery. I read this book 3 times and it gave me hope, which I have been searching for since I got my diagnosis in 1994. The voices in my head were very bad. I tried to commit suicide several times, but luckily I didn't succeed. I tried a lot of different medications, but it did not make my mental health any better. I met my husband in 2004 and got married to Preben. I'm still married to Preben today, but in all other marriages, we have been in a lot of troubles because of my mental health issues and Preben's heart diseases. In 2020, I was asked by my psychiatrist if I wanted to try virtual reality treatment for my voices in my head. I was very skeptical, but decided to give it a go. I was thinking I was too old for this kind of treatment. It was too modern for me. I wasn't comfortable with the VR glasses and the headphones, and I had to get used to it before I could start the treatment. And I thought, I have nothing to lose and everything to win. It could not get any worse. I realized that it was important for me to have trust in the person who treated me. I have experienced that if you have trust in the caregiver, the prognosis is better. And I think it is very important in every relation between a caregiver and a patient. I created my voice as a picture in virtual reality and created the voice as I heard it in my head. It was a very tough treatment, but I had the possibility to press a button in my hand and the VR would shut down. The treatments were done at my pace, so I could stop it if it became too much, which was good for me to know. It made me feel safe. I had a lot of anxiety and felt very bad. I nearly gave up the treatment, but I wanted to see the next corner of my journey. I was beginning to tell my voices off for the first time in my life. I was in virtual reality for 8 times, and about Christmas time 2020, my voices were gone. It was like my life was turned upside down to the very better. I was free. A big burden was taken off my shoulder. I got a lot of energy and could use this energy to tell my story to others. Today, nearly 3 years after the treatment, I'm still free of voices. My life is like a party compared to the life I had before treatment with virtual reality. Before I got free of voices, I used mental health several times a week. And now, 3 years later, I have 1 consultation with my psychiatrist once a year. I'm so grateful that I got the opportunity to get this treatment, and I have a life with purpose, hope, and I think my future looks bright. And now I have 3 take-home messages. For the first, there's hope, even after 31 years in mental health. Number 2, I thought I should hear voices for the rest of my life, but I have been free of voices for 3 years by now. And number 3, VR can be a new way of treating severe mental disorders in the future, but we have to use VR with respect and know how we use VR, when we use VR, why we use VR, and to whom we use VR. Thank you for listening.
Vibeke, thank you. That was extremely powerful. Thank you very much for sharing your experience. That was absolutely wonderful. And thank you, Louise, Lisa, and Lisa. What a great introduction to the session. We're going to have a little bit of time now to have a panel discussion. So I'm in the webinar room with our speakers. And my mind is full of questions. So let me contain my excitement and start where I plan to start. So it's a question to all of you, but I guess, Louise, if you could take this first. In establishing the VR research program, what were the attitudes and responses from other professionals? And I also want to hear some of the reactions that you've had when you go out speaking publicly about the VR treatments, and also some of the reactions from patients, those who it wasn't successful for. But let's start with the professionals and then the public. Louise.
Yeah, thank you, Gregor, for that question. Yeah, so we actually anticipated a lot of skepticism from clinical health professionals, and that wasn't at all what we encountered starting these VR projects. So actually, we met a lot of interested clinicians that found this to be very interesting, very having great potential. But also, when we kind of started the project and we have these great patient stories to share, like me, because it actually illustrated to the clinician that there's huge potential in this kind of therapy. So I think we had a great help from strong voices like Vibeke telling how they got help from this therapy. And then in terms of more public interest, I must say we have had huge media interest in Denmark. So there's a lot of interest in knowing more how you can utilize this tool in mental health research. So we know it from the gaming industry that you can use VR, but how on earth do you kind of integrate that in mental health treatment? And there's a lot of interest in getting more knowledge on this. So we are actually very active in disseminating to the general public here in Denmark. And every time we do so, we get a huge interest from both relatives or like patients wanting access to this kind of treatment. So there is a push in terms of implementing this in clinical practice.
Yeah, good. And so I'm getting the impression that you've used not just the story of the science and the technology, but you've actively used a way of disseminating and interacting with the public to keep two things going at the same time: professional interest and answering all the questions, and secondly, exciting the public and sharing some of the stories and narratives and experiences with the public to generate that excitement. That's an incredibly powerful lesson for others. Can I bring Lisa and Lisa in and ask a little bit here about the safety, the crisis response, and the risk? Give us a little bit more understanding of when things don't go so well, or the technology is difficult, or the dialogue, the confronting dialogue of the voices in the first session can be quite overwhelming. What do you do to ensure safety, being able to respond to risk, and really making sure that your patients are really being well looked after?
Yeah, thank you. So we did encounter, especially in the beginning in the pilot, that the VR was very immersive. And so that voice dialogue was very, there was a lot of anxiety, and that immersion was great, especially in the first maybe 2-3 sessions. So we had to kind of adjust a bit the therapy to manage this. So we went a bit slower forward sometimes in the therapy, not going into the dialogue like right away. That was one thing we implemented. We also have implemented in the VR a beach scenario where you can switch from the nasty avatar and you can switch into a beach scenario where you can just, the avatar is not there and you can relax, and so you can hear waves and you can see clouds, and it's very calming. So we try to use also the VR to make the experience more calming. Then, of course, I want to mention that we have a very close dialogue with the primary caregivers and the professionals around the patient to keep patients safe during this therapy, because we did learn that it is very intense, like Vibeke also said, for most patients. And we have to, of course, first of all, we have to keep patients safe during this therapy. So that was some.
Okay, good. And Lisa, can I come in? The 16% dropout rate, you said a little bit was around the first session. Did you do any follow-up of those that dropped out and really get more in-depth narrative and qualitative perspective as to why they dropped out? Is that part of the ongoing research?
No, and unfortunately, I have and I am still blinded in this trial because I'm the one doing the assessments. So I don't know which patients. I only looked at the numbers. Actually, a colleague did those numbers because I'm not to look into those. So unfortunately, we don't have that. But we have done a qualitative study with interviews from patients going through this trial. And several of them mentioned how difficult it was in the beginning, how anxiety-provoking it was. And then, of course, it should be mentioned with such a severely ill patient group, a lot of things will also happen in their lives. So some might become homeless or other things are happening in their life, adding to a dropout rate.
And may I just add to that, Gregor? So we will be reporting in the main paper from the trial reasons for dropout. So we will kind of know more specifically what were the reasons, because sometimes it may be very practical reasons that they moved away from our clinical facility, so they couldn't enter into therapy or something like that. So not really kind of relating to the therapy or the difficulties of therapy, but more like practical issues in their daily lives. But we will know more about that when we kind of wrap up the trial data.
That's really good. That's so important. And I think if I can just pursue a little bit of line of questioning as well. Lisa, you said about the context surrounding the patient's lives. I think, well, Lisa, I've got to get my, it doesn't really matter who answers the question. I love the way the camera's moving. It's great. So my question really is, the context of people's lives is so important to their recovery. And what are you doing to make sure that the VR therapy is integrated into other aspects of their lives? You talked about primary caregivers, but you know, if someone is experiencing significant employment problems, someone is experiencing housing problems, someone is experiencing threats of violence at home, all of this is contextual to their ability to recover, having enough money, having enough food, having enough of the basics, having good support. How do you make sure that the VR treatment, which is dealing with voice hearing, is integrated to other aspects of the person's care, so it's not just something technologically different over here? How do you ensure that?
Well, first of all, I would like to mention that as part of the trial, patients get a USB with, so they can listen in on the dialogues they had with the avatar in therapy. And this they can also play for relatives, so that the relatives will gain an insight and also can be able to assist the patient if they later on hear voices again or the voices become worse. Relatives or other people It could be the ones working in the psychiatric housing facilities where many of our patients live can also support the patient in remembering what helped before. And generally, we can say that we've had a lot of cooperation with people involved in the patient's lives so that they can also assist the patient both during therapy, but definitely also after therapy. I don't know if
good. And
I think Lisa has a point.
Yeah, great.
Sorry, I think this is a really good question. I think this is a challenge. I think this is a challenge in maybe all therapies, but also certainly in this trial, it has been a challenge because we have very ill patients here. So I think one thing that we learned that we did more after a little while was to bring in to the therapy session like primary caregivers or professionals supporting the patient in real life, so that they could hear what was going on and they could learn also how can you talk with voices, and they could support the patients once they got home and had to practice this, and also if they got like a setback once they came home. Some voices, voices are relational, so once you confront voices, they might, once the patient got home, they might say, then I'm going to scream at you the whole night, or I'm going to threaten you, or I'm going to do things to you once you get home. So we want to have like an arrangement with somebody taking care of the patient once they got home. So this was something that we did spend some time trying to manage that. But I do think this is sometimes difficult.
And so it leads me to my final point before I go back to Vibeke, which is the extent to which, when you're doing the research and you're collecting the data, the extent to which those who are going through the trial and are having, say, successful outcomes, the ability to relate and correlate and integrate those successful outcomes to their housing circumstances, their relationship circumstances, so the other contextual things. So it's the VR in context with the other supports or non-supports in their life, and that then gives a really rich picture of what the VR is doing, but also what's being supported by the other contextual factors in their life. Louise, do you want to say anything about what we can look forward to in terms of the results in the spring, which isn't too far away, can I say, in research terms? I'm super excited about that.
Yeah, so for now, I haven't even got any preliminary results because we're not allowed to look into the data. Unfortunately, I would have loved to do so, but I can say that we have had several striking cases like Vibeke's. She's not the only one benefiting this much. So we have had patients having this striking response, being totally free of hearing voices. Of course, that's not the whole picture. We also have, I would say, 3 groups of patients. So we have patients responding as Vibeke, being free from voices. Then we have another group that might not achieve a full remission of voices, but they learn how to handle their voices, so they're not that distressed by them in their real life. So they can cope with them, they can kind of make arrangements with them to go away for a while. And then we have the third group that is not benefiting that much or like minor benefits. But it's also in terms of timing here, we will look more into the data, is what kind of predicts and response to this therapy, because schizophrenia is a complicated disorder and many factors influence therapy response, of course. But yeah, so we do have these different kind of responses, but we will look more into what predicts a response.
Well, and great, and lots of.
One thing, Gregor, I might add one thing, that we haven't had any like serious adverse events happening relating to therapy, and I think that's also an important kind of point here, that we find it to be safe.
Extremely important. Extremely important. I mean, again, I'm so excited to see the results. It's just such an encouraging research study. So congratulations to all involved. Vibeke, can I come back to you? Can I just say what a fantastically powerful presentation you made, and I loved your 3 take-home messages at the end. Can I ask, after you'd received the therapies, the 8 sessions, and for me, one of the words you used was you became more in control of your voices. What was the reaction of others to Vibeke being free of hearing voices? And particularly maybe share with us the reaction of your husband, Preben, and just give us some of that human insight into the transformative change and the reactions of others.
Thank you for the question. My husband have supported me all the way through the treatment and for the last 18 years. So I can rely on him totally. And that has been an enormous help for me, that I have one person who really believes what I'm hearing, what I'm seeing, how my life is, and he's going through my life together with me. And other people have said, "Oh, you are just in a good period of your life," or something like that. But when I haven't heard voices for 3 years, I really do believe they are going away for ever, you can say. In the first 2 months of my life after my voices left me, I couldn't really believe it myself. I was thinking a lot of thoughts, but as time went by and I realized they are not coming back because I have some methods. So if they were going in my head again, I could say, "No, go away. I don't want you. You have to get out of my life." So I have these methods to use when my life gets complicated. And
Sure.
I use these methods when I have a not very good time. So that's what I learned in the therapy too, that I have something to do for myself when life gets worse.
That's extremely important, extremely important. Thank you. And the last thing that you said was that you really believe in the power of VR, and it's you know, how to use it, when to use it, why you're using it, and with whom. And when you talk publicly about your experiences, those seem to be crucial questions. When you talk publicly, what is the reaction? What are some of the most familiar or popular reactions to what happens publicly when you tell your story?
Most people think that it's very good for me that I have been able to get out of my hearing voices, but there have been some critical moments where people say, "Oh, I don't think you have heard voices at all," and that hurts a bit for me when people are doubting my my life and my severe schizophrenia. But it's a very little part of all the positive things I heard about me telling how I got free of the voices. So it's just a little part, but the main people think that I'm very lucky, and some patients even say to me, "Oh, I would really like to get this kind of treatment. Where can I get it? And who can I go to and speak to so I can get this treatment for myself?" And I say, "You have to wait a little. We have to have this trial done before it hopefully get a treatment in Denmark all over."
Yeah, great. Okay, well, listen, thank you very much, panel. I'm going to open up questions and we'll give some answers to our audience. We've got a question in the chat. Let me just go there and give that, and whoever in the panel wants to answer this. So we've got two, one from Canon. Canon says, intriguing and impressive explanation of psychosis, auditory hallucinations, whichever neurocognitive model is used, suggests an overactive mesolimbic reward or dysfunctional dopaminergic release. How does external stimulus of the avatar's voice in the VR system suppress or override the internal voices? Any hypotheses or explanations? Wow, that's a very, very detailed question. Okay, I'm opening that up. Louise, colleagues?
Yeah. So just in terms of the kind of the neurobiological response or neuroplastic potential alluded to in the question, I would say that we haven't at all looked into that. That is actually step 2 in our research progress, that we would like to add MRI scans to the intervention pre-post MRI to see what actually goes on in the brain. Can we see how do we kind of measure neuroplasticity, because something must be happening in the brain when we see a response like this. So that might help us answer part of this question, but also in terms of predicting a response, may there be some kind of brain-related prerequisites that are needed in terms of change to occur? But then in terms of overriding, I think the voices, you may answer, Lisa.
I think I don't think the word overriding might be the right one. It's at least not what I'm thinking is happening. I think when you think about voices and the relational part of voices, so what we're doing is to try to go in to change that relationship, actually. So really not overriding, but more changing the relationship. And it's a little it differs a bit on the patient how that is happening, actually. But once we're going to VR, for some patients, the real voice is still there, commenting, saying things, saying, you know, you shouldn't do this, or this is rubbish, or, you know, it's all there playing into the dialogue like a trialogue. With the voices there, but other voices are taking a rest at the time. So, and they're intervening after that. It depends a bit, but I think I'm seeing it at least more like going into that voice-patient relationship to try to shift that, because we know that for most patients they feel really superior under the voice. So the voice is like up here dominant, and they feel like really underneath the voice. So we're trying to change that voice relationship. At least that's how we are seeing that. I don't know if that was
okay. Great.
So
no, I think that's a great answer.
Okay, I would just like to add that from clinical practice, we know that when patients are in distress, their voices tend to become worse. So you can also hypothesize that if we lower the stress, if the anxiety goes down, you're less prone to hearing voices. And also with some patients, they experience a difference in what their voices are saying after therapy. And you could also imagine that hearing different voice material from the avatar might alter your memory, so that in the future, you are not expecting to hear evil sentences, which will then, through the brain, of course, could also be a reason why this works for some in a different way by altering the content of what the voice is saying.
Okay, good. I've got two more questions, so keep the questions coming. The next question is from Corin Henderson, no relative, no relation. And Corin's question is, did some patients come off medication to engage in the therapy?
Yeah, so that is a bit difficult to answer at this stage of the research, because as Lisa says, we are still blinded researchers, so it's a bit difficult to look into their medical data. And when Lisa is seeing the patients for follow-up assessment, she wouldn't know if they had the treatment or not. So it's a bit difficult to answer. Perhaps we know of cases that came off their medication, as Vibeke is describing. She now gets a heavily decreased dosage of medication So we know of these at a case-based level, but more statistical evidence. We haven't got that at this stage, but you have perhaps some insight into that.
No, I don't think I have much more insight because we don't know on a group level yet. We know for certain people, but we also have this is 7 sessions, so it's short-term therapy. So also you might want to keep patients on medications for somehow longer, not to risk anything.
Yeah, and we do a 6 months follow-up, and that's what you would say that is a short-term follow-up. So we would need more long-term follow-up data in order to see if the effect of voice remission actually is consolidated, if it's durable, and then you might, as a clinician, be inclined to decrease or a medication dosage. So I think perhaps our data wouldn't be the strongest evidence of this effect, but for sure at a case level, we do see it happening.
Okay, I've got another question, and my apologies if I get the pronunciation of your name wrong. It's from Thorben Peter Hoy Simonsen. What are your experiences with the post-exposure conversations from patients? Are they different from other more traditional therapeutic interactions?
So it was the post-VR?
The post-VR. Sorry, can you say it again?
Yeah, what are your experiences with the post-exposure to VR conversations with patients? And are they different from other more traditional therapeutic interactions?
So you mean after they've been doing the exposure and they come out of the exposure and you're doing as I was saying, I think it is different. Somehow it's similar. You can do exposure in vivo, right? And you come back from that exposure and you follow up on that, and how was that experience, you ask, and how was the target that you had. And so that is similar, I think. But also it is more intense, the exposure in VR. So the follow-up is more like you have to calm down the anxiety. And also you have been in there in that intense experience with your voice and as an avatar. Sometimes they forget that you're the avatar. So they just believe that I'm telling you sometimes what happened in there. So I talked to my voice and my voice was saying this, and this was actually me being the avatar, right? So because I'm playing the avatar. So of course I know what's going on in there.
Okay, good. I'm rushing a little bit because I've got another question, and I'd like to hear the panelist view, but also Vibeke, if you can come in on this one as well. It's from David. I'm curious how the avatar is created. How accurate are they? I mean, is similarity very important? And who does the voices?
I can take this. I actually went with a picture of this man as I heard in my head as a voice. So I came with a photograph of this man, and I gave it to my therapist, and she had some buttons on her screen that she could press and then make the avatar look like my picture. And I have heard from other patients that they have an idea in the head what the voice would look like. And then the therapist and the patient is creating this picture, this avatar together. But I actually have a photograph. And for me,
the voices?
Sorry?
And the voice? Who does the voice of the avatar?
It's a therapist. It's a therapist which voice was, I can't find the word. It sounds like the voice I heard in my head, and it's something to do with the computer. I can't explain it.
Do you hear different voices and you say, oh, that one is the one I feel is more accurate?
Yes, I heard several voices, and I thought, oh, this voice is similar to the man I hear in my head.
Okay, so, perfect. Lisa, Louise, do you want to come in on that just briefly?
We are picking the dominant voice, and I would say that making the visual is easier than making the voice. So the voice was difficult because you don't, as a therapist, of course, you don't hear the voice. So you have to, so the patient have to explain how the voice is sounding, but you can like play it out loud, and then you can listen together and say, okay, it has to be a little bit lower, or it has to have a higher pitch, or, you know, and you can get closer. And we always ask the patient on the visual and on the voice from a 0 to a 10. So how much does it resemble? So we usually go for an 8, you know, we should go up, we should be about an 8. But sometimes we have like something specific, if we have something very specific in the visual, like a hat or a very rare haircut or something, then it's difficult to make that. We don't have that.
Okay, but the technology can advance in that direction. Yeah. Okay, well, thank you very much to the audience for their questions. Really some great questions. I'm sorry I have to cut any more that are coming in. We've got 4 minutes left. I'd like to give each panel member the opportunity. You don't need to take it if you don't want to, but in terms of your hopes for the future and your thoughts, would you like to share one thought with the audience that is really uppermost in your mind just now? So Louise, let's start with you, and then go Lisa, and then Lisa, and then leave the last word to Vibeke.
Yeah, so my hope is that this kind of treatment, not just for auditory hallucinations, but also for other disorders, this VR-based treatment is part of daily clinical kind of practice or clinical programs offered to patients here in Denmark, at least. And I think we have some initial steps that points to what this not being totally unrealistic. Perhaps in a year or two, we might see it out in clinical practice.
Great.
Yes, I would like to mention that with psychosis, we are not used to being able to do exposure therapy in this way, because the experience, what our patients are experiencing, is experienced in a private sphere. So here we have the opportunity to create something alike a private experience and externalize it in virtual reality. And I think, well, I have a special interest in psychosis, and I think this is a great opportunity to work in a different way, but also help the rest of us as clinicians and relatives and society in general, what our patients are experiencing, possibly with the hope of reducing stigma.
Great.
Right. So I guess my hope would be that psychologists, therapists in general would start thinking about when question, when to use VR. So what is the content that we want to use VR? When is the situation? What patients? When can we really make a better therapy with this? This is really my hope, that we can make therapy better and stronger.
Thank you very much. And Vibeke?
Yes, my hope for the future would be that more patients with schizophrenia and eating disorders and so on would be able to get this kind of treatment, because I think it's worth trying to do something which have been very stigmatized, and I think there's hope for almost everybody in the psychiatric mental health hospital. So I hope it will get a treatment in the future. Thank you.
Thank you very much. I would just like to add a huge thank you to each of our panelists for contributing so much to our discussion today. I mean, for me personally, it's been extremely insightful and also moving, hearing about the clinical interventions, the hope and the recovery, and the love that comes across. It feels like a very human interaction. So thank you. That's it for today. It's been such a pleasure having you all with us. Can't wait to see you again at our future webinars. Wherever you are in the world, whatever you're doing, enjoy the next few hours and moments. Thank you very much.